connecting to cloud server. I think it's screenshot this display. You can screenshot on the laptop also, isn't it? Actually, there are people waiting in the waiting room now. You know, want to enter. There's more people. No? Our system can be 1,000, right? Huh? Very good evening. I hope all of you there can hear me. Can I? Okay. Very good evening. It's been the duty of MMA to always keep his members abreast of current topics, current happenings, and of course today the topic which is close to our heart is on COVID-19, the current management, the latest quarantine criteria, and the vaccines. For your information, this webinar carries one CPD point, and at the end of our talk, we will display the QR code which you have to scan to get your CPD points. My dear friends, as I'm talking to you now, the number of reported COVID-19 cases in Malaysia has rose to about 97,000. This is despite all the efforts taken by the MOH, the ministry, including the MCOs, the strict SOP implementations, and of course, travel restrictions. Daily, there are new information or findings about this novel virus, and the latest is about a new strain which is more virulent, which has been reported in UK. Today, we are lucky to have Dr. Suresh Kumar Sidambaram, the head of medical department and consultant infectious disease specialist from Hospital Sungai Buloh. Firstly, on the behalf of MMA Dato, we'd like to congratulate you on your confirmation of Dato-ship by the Royal Highness Sultan of Selangor on the Royal Highness's 75th birthday. Congrats, Dato. Dr. Suresh graduated with an MBBS from the University of Kerala in the year of 1993, and then he obtained his MRCP in 1999 from Royal College of Physicians in UK, and postgrad diploma in epidemiology in 2009 from London School of Hygiene and Tropical Medicine. He obtained his infectious disease training in Hospital Kuala Lumpur and Alfred Hospital in Melbourne, Australia. He has been an infectious disease consultant in Hospital Sungai Buloh since the year 2003. He has also been visiting consultant to many institutes, including the National Heart Institute. He has participated in several international trials, including the HIV treatment trial, and has served on expert panels for national treatment and practice guidelines related to infectious disease, including the COVID-19, HIV, dengue, and adult immunization. Dr. Suresh, I believe, will be talking for approximately 40 minutes, after which he'll be happy to answer your questions. Now, over to you, Dato.
Thanks, Dr. Shiva. Can you hear me?
Yeah, we can hear you loud and clear.
And next question is, can you see my slides? Can you see my slides? Okay. I think what I will do is I will be quite brief, talk about certain parts of COVID-19, and then subsequently that way I can leave a lot of time for questions. In the interest of time, I will not talk about the data that we are having currently that we have COVID-19, how many patients have COVID-19, what are the risk groups and all that stuff, because you get that from the press briefings. So first starting with what do we think are the clinical features of COVID? When we first started managing COVID, our idea of COVID was just that we had fever, chills, and respiratory symptoms. Now we know it is very wide ranging, and so now in fact anything can be COVID. You can have respiratory symptoms, the usual ones. It can be just body ache and fatigue. It can be loss of taste and smell. This is fairly unique for COVID, and in the third wave, because of increasing knowledge, people come and tell us about this particular symptom. But the loss of taste and smell in COVID is quite unique. It is considered absolute. You know, you can't taste anything or you cannot smell anything, and it is also sudden onset, and so it is unique. It is not the one that you get because of stuffy nose. And you can also present with GI symptoms. And so remember that COVID is fairly very wide description now. And that's the reason why if you go back to our guidelines and look at our case definition, in fact, anybody walking into your clinic now can fulfill the case definition for COVID, because any two of these symptoms, any one of these symptoms, and you're coming from a red area, you know, red zone, which is in Klang Valley, any part of the country, any part of the state varying some few districts is red. And so it is easy for someone to fulfill the case definition for COVID. How is it spreading? What do we know about the spread? This is from US CDC website. It says primarily it is by droplet transmission. But however, airborne transmission can happen in enclosed spaces where there is prolonged exposure to respiratory particles, often generated with expiratory exertion, like shouting, singing, exercising, or inadequate ventilation or air handling, where there is a buildup of small respiratory droplets and particles. I will explain these in a bit more detail with some diagrams. So as you can see here, somebody is talking versus keeping quiet, talking versus singing or shouting. The amount of droplets they send out is different depending on what they're doing. And so the worst thing will be somebody shouting or singing without wearing a mask, and you can release within an hour about 1,500 infectious doses of the virus that can be sent out. Examples of how all these plays up in the risk. There's a very nice article piece written in this Spanish journal. Here is a patient. This patient D is COVID positive, and it's a closed up room. People are staying with him. People are staying with him for 4 hours. Everybody becomes positive. Everybody wears a mask. Then most of them are still positive except for one, but nothing else is changed. Right? If you were to do everybody wear a mask, very good ventilation in, and you shorten the length of time you stay there, just one person next to the particular person can be infected. So it is just not mask, it is a lot of things together, you see. No prolonged contact, good ventilation, in addition to mask. Same scenario in a restaurant. Patient O is infected, and then closed up restaurant. A lot of people staying in the same restaurant for over 4 hours. All the 14 customers get infected. Change the scenario. Alter the whole thing a bit. Bring in a lot more ventilation. Get everybody to wear a mask. Space them out. Then the infection is down to only 1% just next to the infected patient. And the school as a scenario, the teacher is positive, she's not masked, students are staying together. Then in this particular scenario, 12 students get infected. The students stay for two hours continuously in the same classroom. Modified a bit, everybody wears a mask, then the number drops to 5. Only 5 people get infected. Everybody wears a mask, including the teacher. You create ventilation, open up the windows, keep the windows open. Make sure. And so keep the ventilation going, and regularly students are asked to take a break, go out or take a break every hour. Then the infection drops to just 1%. One last example I want to show you is the outbreak in call center in South Korea. So it's a call center. People are sitting down like this in a call center, and they realize that about 137 workers, 79 get infected in the same day. So enclosed space, everybody sitting close together, and almost everybody gets infected. But in the same floor, other parts of the building, only 5 people get infected. And the rest of the floor, only 3 people get infected, despite everybody using the common elevators, the common rest areas, because it is transient, because it's not an enclosed space, others don't get infected. Okay. So you sort of get an idea what we are supposed to do when we want to prevent COVID infections. The first one is physical distancing. It's important. So teleworking, reducing number of employees in the office at any time. The second one is engineering control, creating physical barriers between people, putting up plexiglasses. Administrative control, redistributing responsibilities so that we can reduce contact between people. And last is mandatory use of masks, non-medical masks. So this is not the only thing, and we have to do a whole lot of things to decrease, to improve physical distancing to happen. This, in addition, I also show you the importance of ventilation in preventing COVID. Okay, that's regarding the COVID. The other big question people always ask is about surfaces, and these are series of studies that have looked at COVID in the surfaces. Virus highly stable in low temperatures, but is sensitive to heat. It gets inactivated even 5 minutes at 70 degrees centigrade. It's susceptible to common disinfectants. So when people have done a lot of environmental studies, they have shown that environmental contamination is commonly found in dining utensils, high-touch surfaces where everybody touches very often, and toilets. But we have found the virus by PCR. We don't know what's the significance of that. A PCR positive, does it mean it is infective virus? We're still not sure. So with regards to the role of direct contact and fomites, no, there is no strong direct evidence yet, unlike the one I showed you regarding droplets. So contact investigations have pointed out to a possibility of getting infected while using elevators at restrooms, but people have never shown a concrete evidence. It's because the viral load of a live virus transiently found in public places is low. So it's unlikely to be an efficient mode of transmission. So if you are going to get it from one of these surfaces, I think that is extremely unlikely, but it's not the most common mode of transmission. That's regarding how COVID transmits and how what common sense stuff that we need to do to prevent from getting infected. Next is regarding infective period. Okay, so this is the meta-analysis, systematic review of all the studies that look at infectivity. So I just want to point out what infectivity means. PCR positive means you've got a live virus, dead virus, or a viral fragment. You cannot differentiate the three. So, but if you do a culture and it's culturable, then you're dealing with a live virus. And so the general thinking is the live virus means infective. Live virus is not, you cannot culture the virus, but it's PCR positive means non-infective. So many of these studies have shown that the peak viral load in people, that means the peak infectivity, happens at day 0 of symptom onset. If somebody is symptomatic, I'm not talking about asymptomatic people here. If somebody is symptomatic, on day 0 of the symptom, he's got a peak infectivity.
Apparently, I see how, chat meeting session minimize.
Majority of the secondary infections people have found occurs prior to day 5. It's a very nice Taiwan study. They showed that most people who got infected from an index case happened because they met the index case less than 5 days of illness. If they met the index case on day 6, they couldn't get the disease. So most people get the disease with less than 5 days from the onset of symptoms. People have, somebody has got a mild to moderate disease. That means somebody has got a disease that doesn't require supplemental oxygen, mild to moderate disease. We are unable to culture the virus beyond day 10. Beyond day 15, the chance of you culturing the virus, even in a critical ill or immunocompromised host, is less than 5%. Day 20 is the longest duration an infectious virus ever been cultured, reported to date. So beyond day 20, the guy can be very ill, sitting in ICU, ventilated with multiple tubes everywhere, but we can't find live virus inside him. Okay? However, even up to 90 days, the PCR can remain positive. And that's a tricky part of this particular virus and PCR. And so based on this, our discharge criteria currently is in somebody who's got COVID symptoms, if you have completed 10 days since symptom onset, and at least 24 hours has passed since resolution of fever without use of fever-reducing medications, and other symptoms have improved, we discharge them. So symptoms have improved, and you have finished for 10 days since onset of symptoms, we discharge them. Sometimes people come and get admitted at day 7, day 8. So we keep them for 2-3 days and then we discharge them. But if somebody's never got symptoms, never had symptoms, then we take the day of the test as day 1. So they'll be discharged 10 days after the first positive PCR test, and these are discharge criteria. So as you can see here, this is actually a diagram that just tells you the fatality rate versus infectivity. Okay? Fatality rate is infectivity, as we all know. COVID apparently comes here, somewhere here. So it's very astonishing why a disease that is not the most infective or not the most fatal is causing so much havoc compared to all the other viruses that we've seen so far. Why is it causing so much havoc? And I think the single most important reason is because of this. In symptomatic people, I'm talking about people who ever get symptoms, right? 44 to 70% of transmission occur during pre-symptomatic period. See, can you see here? This is the day you get symptoms. Before the symptoms starts, the person is already very infected. The viral load is very high. And so that's the reason why I think this disease is creating so much havoc. Before I know I've got COVID, I would have passed let's say I'm destined to pass to 10 people. Let's say I'm destined to pass to 10 people. Up to 7 people I would have passed before I even knew I had any symptom. And that's what is challenging about preventing COVID. So 44 to 70% of transmission occurs during pre-symptomatic period. Okay? In fact, there's a very nice household study done in US. They looked at all the household where there was an index person as COVID, and then they tracked everybody and see how many people get COVID and when they get COVID. And they found that 75% of the infections are identified within 5 days of index patient's illness onset. Again, same thing. Right? So most infections happen within 5 days of index patient's illness onset. Okay, and so this comes down to the new guidelines that DG has sent out regarding travelers, right? So regarding travelers and how long we need to quarantine them, right? Okay? So this is what there's an infographic from Ministry of Health says this, right? If somebody comes in from abroad now we check for temperature. If your temperature, you go off to the same way like any other symptomatic person you manage. If you have no symptoms, that's the most common scenario, you have no symptoms, then what happens, we will look at your COVID result that you bring along. If you bring along a COVID result and it looks valid, then you are only quarantined for 7 days. And you have to do antigen or a PCR test 2 days before the end of your quarantine. But if you don't have any valid COVID result, then you are quarantined for 10 days again, 2 days before the COVID, before the end of your quarantine, 2 days before the end of the quarantine, you need to go and get a PCR or an antigen test done. Right? And so this is again the same thing in a different diagram, right? So this is your day of departure, day of arrival to Malaysia. So up to 3 days before the arrival, you do a swab. The swab is negative. So you have a negative swab. Then what happens? You're quarantined only for 7 days. But you need to take a swab 2 days before the end of your quarantine. But you have to continue monitoring yourself for 14 days. You don't have a swab before, you are taking a swab on arrival. And then you're quarantined for 10 days. And you get a swab 2 days before your end of your quarantine. But you continue your home, your surveillance using the Sejahtera app for 14 days. And that's the current take on travelers that are coming back from abroad. Okay, so this is based on actually modeling studies done by US CDC, and US CDC modeling says this. Right? I'm using this 10-day. If you're doing a 10-day quarantine, if you don't do any test, then the chance of you residual transmission risk, the chance of you transmitting is 1.4%. If I just quarantine you for 10 days. If I do a PCR 2 days before the end of quarantine, 48 hours before the end of quarantine, the risk can be decreased 0.3%. If you do an antigen test, the risk can be decreased to 1.1%. So this is the one that we are going towards. Of course, if you do 14 days, of course, it's pretty good. But we think, you know, the number of people who are positive on second test is so low that this risk is worth taking, right? And that's the reason why it was made into 10 days. So the next one I want to talk about is COVID-19 versus COVID-19 PCR positive versus infectivity. This is something that I discussed earlier. Okay? So I mentioned about using cultures to determine whether somebody is infective or not infective. The best study that was shown recently published, they looked at 90 PCR samples and they grew it in viral cells, and they were able to grow 30% of those samples. Right? So they were able to show that if CT value was more than 24, in that particular study, CT value more than 24, or day of illness is more than 8, the chance of you, there's no chance of growing those samples. Okay? So I'll tell you what CT value means. CT value is cycle threshold, and so in simple terms, it's about how many times you multiply the specimen so that the virus reaches a certain level that the PCR machine can pick it up. And so if I have lots of virus in my body, my sample will have lots of virus. So I need to multiply it very few times to reach the level that the machine can detect it. If I have very little virus in my body, that means the machine has to multiply the virus in my body, virus in my sample many times before it can be detectable by the machine. And so a high CT value means technically I've got low viral load. Low CT value means I have high viral load. Okay, so that's the general understanding of CT value, right? So if CT value is more than 24, that means low viral load, and or the day of illness is more than 8, then we cannot culture the virus. In fact, the probability of obtaining a positive viral culture peaked on day 3. So at day 3 is where the maximum positive viral culture happened. In fact, the study went on to give us this mathematics. Every 1 unit increase in CT value, the odds ratio of being culture positive decreased by 32%. For every day increase in day of illness, the odds ratio of being culture positive decreased by 37%. So I'm showing multiple data set that tells the same thing, you know, that the infection happens very early, and PCR positive does not always mean infective virus. Okay? And so this is what we are faced with, right? So if I were to do a PCR on somebody, the PCR goes up, and then it remains positive for a long time. PCR remains positive for a long time, right? But if I look at infectious virus, the infectious virus only until this time. And so a PCR positive at this time is useful for us because this guy is infectious, I need to isolate. A PCR positive here is actually a nuisance because it worries all of us. We don't know what it means, and is of no public health significance. But that is a test that we have. So PCR has high analytic sensitivity, and so it picks up people in the post-infectious phase and who are no longer infected. In fact, some people argue antigen test that we do has got a low analytical sensitivity, and maybe it's a better at picking up the infectious COVID patients, and it doesn't pick up so much the non-infectious COVID patients. Okay, so that is an argument that still needs to be tested with regards to use of antigen test for this scenario. But I showed you the CT value just now, but remember the problem with CT value. The College of American Pathologists sent out a proficiency test for 700 labs in US. So they sent a specimen to 700 labs, asked them to do a PCR and tell us. And they found different missions reported different PCRs. And the CT values varied up to 14 cycles. And so you cannot compare one CT value from one mission to another CT value in another mission, unfortunately. And so that's the reason why microbiologists don't allow us to use CT value to determine this patient is infectious, this patient is not infectious, because they said there is too much variation with missions that are currently available, and these have not been standardized yet. Okay, so the other thing that I want to think about is asymptomatic infections. What is the importance of asymptomatic infections? So the first thing is, how common is asymptomatic infections? I think asymptomatic infection is not as common as we believe it to be, because initially when we talked about asymptomatic, we thought COVID only causes fever, cough, sore throat. But now, you know, it can cause body ache, it can cause vomiting, it can cause diarrhea. And so if you put it all together, many papers say only 17% remain asymptomatic throughout, and ranges from 6 to 41%. In another study, it was shown that 25% are asymptomatic, but eventually many people get symptoms and only 8.4% remain asymptomatic. And so truly asymptomatic may be a lot lower than what we think it is now, right? The second information that we know is asymptomatic person versus symptomatic person, the viral load is quite similar. The amount of the viral load of the person is very similar, but yes, an asymptomatic person clears the virus faster than a symptomatic person. The viral load is clears up faster, but the viral load is similar, right? So mathematical modeling paper says a relative risk for asymptomatic transmission is 42% lower than a symptomatic transmission. So an asymptomatic person asymptomatic person transmits half as efficiently as a symptomatic person. But that is quite controversial. Many people are also contesting this, because they argue that asymptomatic person is more likely to be out in the community than isolated at home, and so he's got more opportunity to spread. And so this whole question of, you know, in public health, that's a big decision, big dilemma. And we are swarmed with cases. Should we focus on asymptomatic or not? Because the jury is still controversial. Okay. The other thing I want to talk about is close contact and isolation duration. This is the science behind close contact, right? And every time I know there's so much difference in the interpretation of whether somebody is a close contact or not. And I think the reason is because defining a close contact is not a perfect science. It's more experiential, and actually some of it you can argue might be gut feeling. The reason is because of this, right? So for close contact, you have to look at three questions. Question number 1, did the contact happen during the infective period? That is the first question. So when is the infective period? 2 days before the illness onset. For asymptomatic patients, there is no illness onset, and so we say 2 days before the specimen collection date, until the time the COVID-19 case isolated. And so if the contact happened 3 days before, you are not a close contact. If the contact happened after the person was isolated, you are not a close contact. So that 1 second. The second question is, was it a close or a prolonged contact? And or a prolonged contact. How do you define that? Okay. A face-to-face contact with COVID-19 within 1 to 2 meters. I wrote the 1 to 2 meters because different countries use different. I think we use 1 meter, Europe uses 2 meters, and so different people are different. For more than 15 minutes. So face-to-face contact within 1 to 2 meter 1 to 2 meter distance for more than 15 minutes. Or had a physical contact with the COVID-19 case. I touched him, then there's no point talking about now whether you are 1 meter away or 2 meter away or 3 meter away. I touched him, I shake hands with him. So physical contact is already a close contact. Right? Unprotected direct contact with infectious secretions of the COVID-19 case. Yeah, I was there only for 5 minutes with him, but the idiot coughed on my face without a mask. Then that's already a close contact. You don't need to have 15 minutes, you don't have to have anything else. And so direct contact with infectious secretions. Exposure was in a close environment, like household, classroom, meeting room, hospital waiting room, etc. with a COVID-19 case for more than 15 minutes. I was more than 2 meters away. He was in that corner, I was in this corner. But the room had no windows, nothing. It was a cramped up room, confined space. Then it is an exposure nevertheless. And so all these things matter in a close or a prolonged contact. And the next question, last question is, was the exposure accompanied by inadequate PPE? So if either one was not wearing a mask, either the patient or the contact was not wearing a mask, it is considered a close contact. And so we need to apply all these 3 things to decide whether you're a close contact or not a close contact. Okay. So again, there is a new guideline that has come out that discusses about how to manage close contacts. And so what does it say is this, right? It says similar to what I've said for travelers. It says, the close contact for quarantine period for close contact has been decreased to 10 days. The quarantine period for close contact has been decreased for 10 days. Okay. So, but 2 days before the end of your contact, 2 days before the end of your contact, you need to do a COVID test again. So you need to repeat a COVID test 2 days before the end of your quarantine period. Very similar to what I suggested for travelers, right? And it says you still have to follow up yourself for the next 14 days. So that is for close contact, quarantine period for close contact, very similar to travelers. Quarantine period is for 10 days. 2 days before the end of your quarantine period, you have to do a COVID test. And the COVID test comes back as negative when you release the day 10, but you need to continue to follow up for 14 days. I just want to highlight something here, right? And when we talk about this quarantine period for close contacts, we are talking about individual isolation. We are not talking about group isolation. This is for individual isolation. And we say the quarantine period is 10 days. It means it is for individual isolation, not group isolation. What is the group isolation, individual isolation? So I'll give you a case. I'll just show you an example of army military recruit scenario that happened in US, right? Okay. So these are military recruits, 1,848 military recruits. And so they wanted to try military training for them, right? Okay. And so they were asked, so they were very strict. They said you have to do a 2-week self-quarantine period at home, and then you will be brought into a college campus where you will be on a supervised quarantine. So you're under quarantine, but you're supervised. And so very, very military style. You are put 2 in a room. Yeah, you're put 2 in a room, but after you use the toilet, you have to wipe down the toilet. You go and eat in the dining room. After eating, you have to wipe down the surface before the next person comes in. So a lot of strict rules with regards to quarantine. Despite that, 16 recruits are positive on arrival. So you can understand that, right? 16 recruits on arrival. So that means the 2-week self-quarantine didn't work at home. So 16 recruits are on arrival. But then they are on a supervised quarantine after this, they are on a supervised quarantine. Despite being on supervised quarantine, 24 of them subsequently test positive on day 7. 11 of them test positive on day 14. And so as you can see here, if you're on a group isolation, 14 days is not enough, because when you're on group isolation, what happens is somebody will be on incubate. When I do the test today or day 14, some of those negative will be incubating the virus. And then the day after the test, they will start infecting others. And this is what is happening in many of all our prisons is what happened in all this crowded accommodation for foreign workers, same things happening. So we are continuously infecting again and again and again. In situations like that, the only way to finish up quarantine is you have to keep on doing at regular intervals the test until for 2 consecutive tests, there is nobody positive. So when I talk about isolation for 10 days, we are talking about individualized. Everybody stays in one room. We are not discussing group isolation. We need to differentiate them. Okay. Moving on to clinical management. So early in the disease, for us to understand the disease, we classify COVID into these groups. Category 1 is asymptomatic, category 2 is symptomatic with no pneumonias, category 3 is symptomatic with pneumonias. These 3 were considered mild COVID. And when somebody requires oxygen or somebody requires ICU care, we call them severe COVID. And so this is how we classified them. Okay? And we also studied our first 6,000 patients that we had initially, and we knew that 5,400 of the 6,000 patients, about 92% of them had mild disease, category 1, 2, or 3. Only 8% of them had severe disease, category 4 or 5. So 8% had severe disease, 92% had mild disease. That's what we know, right? And so we want to know who are the ones that get severe disease, right? So that's what we want to know. So this is what we found out. Right? So stable means they come to the hospital not requiring oxygen, category 1, 2, or 3. Worsen means after coming to the hospital, they deteriorate and then they go on to get severe disease. Okay, so this group, we're talking about this group. The 2, 10, and 63 on arrival, they already had severe disease. This 30, 84 came in very stable and subsequently developed severe disease. 3.5% of the population developed severe disease. So we characterize this 3.5% and find out who are these people. Okay, so if you're 12 to 30 years old, the chance of you deteriorating is 0.36%. If you're 51 to 70, the chance of you deteriorate is 9.61%. And if you're 71 years and above, the chance of you deteriorate is 33%. And so age at which you get the disease really matters. And then what we did, we also added comorbidity inside, right? Okay. If you're less than 50 without comorbids, which is majority of the people that got infected in the first and second wave, you have 0.96% chance of deteriorating. On the other hand, if you're more than 50 with comorbids, you have a 15% chance of deteriorating. When I say deteriorating, that means you requiring oxygen or requiring ICU care. So 15%. Overall, it is 3.65%. So this is what we have. So, and also we have mortality data. The mortality data is a bit old, but figures are always similar. So 85% of the people who die are more than 50 years old. Okay, more than 50 years old. 85% of them die. And also, if you look at age-specific mortality rate, as you can see here, after 50, it sort of falls away. 1.5% of those more than 50 die. 4.23% of those who are 60 to 69, and if you are 70 to 79, it's 10.96%. I'm not sure why 80 plus are protected, but I presume these are all small numbers and restrictions. Okay. And so what we have done is we've put all these data that we have from our first and second wave into a simplified treatment approach, because we needed a simplified treatment approach to manage thousands of patients that are coming into our treatment. And so this is what we do, right? So if you're less than 50 old and no comorbids, you have the lowest risk of deterioration. So we admit them into low-risk centers. If you are, on the other hand, if you are 50 to 70 with comorbids, we put you in a hospital, And of course, more than 70 with or without comorbid, we put in hospital. The 50, this group, less than 50 with stable comorbids or 50, 70 no comorbids, depending on the hospital, depending on setup in the particular state, either in PKRC or a district hospital or a smaller hospital. So we determine right from the beginning your risk stratify you based on these two parameters only, age and comorbids. Okay. The other thing that we also looked at is we learned we want to say, as I mentioned, we have simplified treatment algorithm. So who gets severe COVID? So this is the same thing that I mentioned to you earlier. Age more than 50 and comorbid. I'll just explain the comorbids: chronic kidney disease, hypertension, cardiovascular disease, obesity, BMI more than 30, pulmonary disease, and uncontrolled diabetes. So all these are the most common comorbids that we get. Okay? When you deteriorate, day 5 to day 10 of illness. So people come to us very well, and sometimes we get what should we say, hoodwinked by that, because I've been seeing this guy for the past 5 days. You know, every day is well, but they start deteriorating at day 9 or day 10, and so sometimes so the deterioration happens at day 5 to day 10 of illness, and many times we see it at day 10 of illness and catches off guard sometimes. So deterioration is later. Okay, how do we predict the deterioration? So we wanted to use dengue as a criteria, and so we started calling them warning signs. And these are the warning signs that we look out for. So every day we see a patient, this is what we ask them: do you have warning signs? Warning signs are fever, persistent fever, exertional dyspnea, persistent cough, persistent symptoms like lethargy, poor appetite, nausea. And so usually by the time they come to us, they're already well, but they're still lethargic, their appetite is poor, nausea, they still have nausea. We will think of them as warning signs. Right? And then hypoxia is evidenced by respiratory rate increasing, SpO2 less than 95%, or exertional hypoxia. When I walk a bit, I rasa symptom. So we use that. Right? And then we have laboratory markers, rising CRP or a single CRP more than 5. It depends on which hospital you have. Sometimes it's 5. If your unit is liter, milligram per liter, it's 50 milligrams per liter. Sunya Blue, it's milligram per deciliter, so it's 5. So most hospitals, it's more than 50 milligram per liter. 50 milligram per liter is considered high. Or dropping absolute lymphocyte count, or a single absolute lymphocyte count less than 1,000. Or you can also use a neutrophil lymphocyte ratio of more than 3.13. Or chest X-ray showing multilobar involvement or rapidly worsening. So these are the warning signs we look out for in every patient. And so these warning signs, you need a lab test, but these two warning signs, you don't need a lab test. You just need a history and vitals. History and vitals enough to pick up these warnings. And we also realized that we can't be doing chest X-rays for everybody. And if 1,000 patients get admitted, if we start doing chest X-rays for 1,000 people, we realize that we never can triage these patients. And so we are now using extensively exertional desaturation, sorry, chest X-ray in the low risk groups. Age less than 50, no comorbids, we do exertional desaturation. This is something that we can do in office too. So we ask the patient to sit and stand as many times as possible for 1 minute. And then we look for a 3% drop in SpO2. Let's say 96 beforehand, and then it drops down to 93 or 95. Sorry, 3 last, so 98 beforehand, and then now it drops to 95. That means more than 3% drop. That means it's got exertional desaturation. In fact, we found this more useful than a chest X-ray because many people have chest X-ray opacities with something wrong with them. But they have exertional desaturation, that usually means something not right with them. And so we find exertional desaturation very useful. And so if any of you got admitted in the hospital, you realize that we started doing this for patients regularly. Okay. So lastly, sorry, the other thing that I want to talk about is medical management of COVID. This is our understanding of COVID. Early in the disease, there's a viral response phase. And later in the disease, it's a host inflammatory phase. That is what causes the disease. Something similar to what happens in dengue too, right? Okay. And so, as I told you earlier, clinical category 1, clinical category 3, 4, 5, right? Okay. So by the time they start getting pneumonia, by the time they require oxygen, the virus is no longer of concern. What is of concern is the host inflammatory response. Okay? And And so while early in the disease, the virus is the problem. So an antiviral will work early in the disease, while later in the disease, we need to use anti-inflammatory agents, and that's how we manage COVID-19. And so we use anticoagulation, low molecular heparin for almost everybody with oxygen. We use an antiviral called favipiravir, and we also use steroids steroids and an immunomodulator agent called tocilizumab in the immune phase of the disease. And, that's how we manage COVID-19. All these three combinations are given. Okay. So the question, of course, is when will this all end? For us, as you know, our numbers are our first, second wave we were over prepared, and third wave, whatever amount of preparation doesn't seem to be enough for third wave. So I can tell you that we know how to stop COVID. I think COVID can be stopped. The reason I'm saying that is because this is based on the non-pharmacological interventions that is used to stop COVID. And as you can see here, the non-pharmacological intervention that's very useful will be stuff like stopping gatherings, closing education institutions, border restrictions, individual movement restrictions, national lockdown, mass gathering cancellation. You do all this, COVID comes down. And the problem is the discussion that we're all having is life versus livelihood. So if we were to do all that, we could save lives, we could stop COVID, but what about the livelihood of people while we're doing that? And that's a sad, that's the balance that we're all struggling to decide where the balance should be. And so in the meantime, I think we will have to learn to live with COVID-19 for the near future, mainly because our public health system is already overburdened currently, and that we have about 3 million foreign workers. We have porous borders, and so we continue to have introduction of COVID-19 inside. And I think we will have to have a whole society approach to managing this COVID alone, what we can do. And we need to refocus on the vulnerable group. As I showed you earlier, in most countries, what happens, the healthcare system gets overwhelmed. So when the healthcare system gets overwhelmed, you know where it happens. It happens in the vulnerable group. The ones that I showed you earlier, more than 50 comorbidities. Our aim is to decrease mortalities and we need to adopt new norms. In regards to the vaccines, many things that I know comes from news briefing, just like you. So there's a news briefing saying that you'll be getting enough vaccine to cover for 60 to 70% of nations, and first batch of 12.8 million vaccines will come in as early as March next year, but it will be staggered throughout 2021. Okay? So this first vaccine, only 2 vaccines have been approved. That is the Moderna vaccine and the Pfizer vaccine. So it's a very unique vaccine. It's a future vaccine. I think most future vaccines are going to be like this. So it's actually a messenger RNA. It's a messenger RNA that is bottled up in a lipid coating. And so you inject it. So what happens, the messenger RNA gets incorporated into our cell. And then the messenger RNA produces the spike protein, this protein in the virus. So it produces a spike protein. So now what happens, the spike protein comes out. Now body starts producing antibodies to the spike protein. So by having antibodies to spike protein, we are now protected against the virus. So it's a fairly novel way of creating immunity. As you can see here, but there are many different approaches to vaccines that are being tried now, in addition to the one that RNA virus, messenger RNA vaccine that I showed you about. Okay, and many of these vaccines have got lots and lots of patients in the clinical trial. The Pfizer one had 44,000 patients in the clinical trial. Moderna had 33,000 in the clinical trial. The Oxford vaccine, 64,000. Janssen is doing about 90,000 patients. So by the time the vaccines studies are done, I think there are lots of patients already on the trial. In regards to efficacy, the 2 vaccines have shown efficacy of about more than 95%. So it looks like there is a future of vaccines. Oxford vaccine came down to 70% and the Russian Sputnik vaccine was 92% effective. these two have got a similar method of producing. Okay. As you all know about the challenges of the vaccine, both the RNA vaccines has to be frozen, while AstraZeneca and Sputnik vaccine does not have to be frozen. Many people asking us regarding the Chinese vaccine. In fact, I spoke to my colleagues who are now evaluating the different vaccines, and they said, they have hardly any information from about the Chinese vaccine. In fact, the Chinese have not published anything. In fact, the first results for the Chinese vaccine came from UAE. UAE says it is 86% effective after giving to the 30,000 people. So we have very little information about other vaccines for us to decide whether we should buy these vaccines. The only two vaccines that we have information about is the Pfizer vaccine and Moderna vaccine. Even the people sitting in the ministry don't have information about other vaccines yet. It's all what is available in the newspapers, news briefings. And of course, as you all know, with regards to the way we are going to vaccinate, the current thinking is it will be given for frontliners, and then subsequently for those elderly and those who are going to get severe disease, and that is the plan for vaccination. With that, I will end, and I'm happy to answer questions. Thanks.
Thank you, Dr. Suresh, for the very informative talk. We are waiting for questions. Actually, we have about 10 minutes for questions. To get the ball rolling, Dr. Suresh, can I ask the first question? You told us now on the day 8 of somebody's quarantine, they should do one of the tests. Is it PCR or antigen is enough?
The circular says PCR, but I believe PCR, because the reason is because I think currently contact tracing is still done by Ministry of Health. But for me, as far as I'm concerned, it's PCR or antigen test makes no difference, because the loss of the transmission potential is very small. So scientifically, it doesn't matter it's an antigen test or PCR. But the guideline, when I looked at it, it talked about PCR for contact tracing, while it talked about antigen test or PCR for travelers. For travelers, it is very clear. It mentions antigen test or PCR.
Dr. Suresh, plenty of questions coming in. One is on vaccination. Will the vaccination be an option basis or compulsory for everybody?
It can't be. I doubt anybody can make it compulsory. It will be optional, but I think I'm convinced that is the best exit strategy. There's no other exit strategy that we have without vaccine. I don't think we can control this. And by that time, so people ask, is it safe? Is it safe? They say, what is your hurry? You don't have the vaccine yet. It's not like tomorrow somebody's going to give it to you. So we will have another 2 months of data that is going to come in. And US is going to vaccinate millions of people. UK is going to vaccinate millions of people. And every guy who's getting vaccinated is going to be looked at it under a microscope. And so I think by the time vaccine reach our source, we will have very good safety data. And we just have to wait for it. And until then, whatever data out there is premature.
Yeah. Another interesting question, Dr. Suresh. How about reinfection? What's your view on that?
Extremely, we are still learning about reinfection. The current thinking is most of us produce enough antibodies for us not to have reinfection for the next 3 months. In fact, US CDC guideline says, if you're COVID positive, next 3 months, don't do a PCR, because you don't understand what it is. And so reinfection is very, very rare, because if reinfections are common, we have had, let's say, millions of people positive, and with reinfection, we should see a lot more. So reinfections can happen, especially if your first infection was very, very mild. If your first infection is very mild, then there is a possibility you can get reinfected, but it is extremely rare.
Another question is, when the patient is discharged from the hospital, when is he allowed to go back to work?
Next day he can go to work, he is not infected anymore. Provided he is well. So many times we give them leave because they are tired or something like that. Other than that, if the MC is finished, they can go back to work.
Okay. How good is the RTK antigen test in an asymptomatic patient?
That's what I'm saying. Antigen test picks up only the high viral load. It doesn't pick up the low viral load. Okay, it doesn't pick up the low viral. It only picks up the high viral because there's no amplification process, right? Okay, and so the question now is the question that we ask. We are all asking ourselves is: do we need to pick up these low viral loads? What do these low viral load mean? They are PCR positive. So what? They don't transmit. So we don't know what this low viral load means. But antigen test will never pick up low viral loads. Only pick up the high viral loads. Most people in the first week of illness have high viral loads. The second week of illness, they start having low viral loads. So antigen test is very good at picking somebody in the first week of illness. The second week of illness is not very good. So it will miss people in the second week of illness. So, but we don't know the public health significance of missing somebody in the second week of illness. Okay? And so that is the answer that I can say.
Another interesting question, Dr. Suresh. How about high dose of vitamin D and vitamin C for those who are above 50 years old? Any help?
I mean, I've gone through COVID-19 saying, when we started COVID-19, I said Kaletra is the best drug for COVID-19. Then I said hydroxychloroquine is the best drug for COVID-19. So I'm after doing all these things, I'm a bit reluctant to say any drug is good. I don't know whether it's worth using it or not. Some people suggest vitamin C. I think there's a question about ivermectin also. So we are all looking at those and we are asking ourselves whether we should study ivermectin. But vitamin C we do use in our ICU patients. We do use it, but use it in very high doses, parenterally, in some patients who still have hyperinflammation despite giving them steroids. Because it's an antioxidant. So some ICUs try vitamin C, but we don't have very good data for vitamin C. We don't have data for vitamin C as a prophylaxis.
Okay, another question of Suresh. If RTK antigen detects high viral load, then why or when to do PCR on this negativity?
Okay. So the way we work is, the end of the day, you should realize this for public health purposes. Antigen test is less sensitive. Okay, less sensitive because it doesn't pick up. But antigen test will come back immediately. PCR takes 2-3 days to come back, right? And so because I transmit the disease early I transmit only early in the disease. Some people argue a less sensitive test for which the turnaround time is very fast is a better test than a more sensitive test, but the turnaround time is 2-3 days. By the time the result come back, you already transmitted to many people. So that is the argument with regarding antigen test PCR test. Right? Okay. So if antigen test is negative, you're still not sure whether this guy is COVID negative or not. So if he continues to have symptoms, you could repeat the antigen test or ask him to do a PCR test. That is one rule. So negative antigen test, but if he still has symptoms, you can ask for a PCR test. If antigen test is positive, and he's coming from a population where there is so much COVID, like a foreign worker, then what happens? The antigen test is confirmatory. But antigen test is done in a person where the risk of COVID is very low, right? Then what happens? That is why the recommendation is you keep the buffer of the antigen test and send the buffer for PCR. So we will confirm the antigen test with the PCR result. So two things are a negative antigen test. If patient is still symptomatic, you might have to repeat it with a PCR or an antigen test subsequently. A positive antigen test, you interpret it based on whether it's in a high-risk population or low-risk population. Currently, for high-risk population in Klang Valley, foreign worker, staying in all those crowd accommodation, antigen positive, it predicts PCR positive very well, just like what happened in Sabah. So antigen test positive is enough for us. But if you're doing it in a person, traveler, he doesn't get high-risk exposure, nothing, then if the antigen test is positive, then we will ask you to send a buffer over to us. We will do a PCR on the buffer.
Dr. Suresh, if we perform antibody tests to all Malaysians, can we rule out patients for vaccinations?
The first thing is that, if I do an antibody test for everybody, I have a feeling we will get 5 to 10% of the population positive. It will be very small. Everybody who has done sero surveillance, have found very low positivity rate by antibody tests. That's why people have gone away from herd immunity. Okay, so the first thing is most countries have shown that antibody positivity is very low. Right. The second problem for us is the antibody test is transient. So antibody negative doesn't mean they are COVID. They are COVID negative. They have never had COVID before because antibodies can be quite transient. And so I don't think there is a plan to do an antibody test and then vaccinate. I don't think there is a plan. Nobody is doing it. People are just finding high-risk groups and vaccinating them because the number you can decrease by doing antibody tests for everybody is very small. You as well vaccinate everybody.
Is there any studies, Dr. Suresh, on how many positive PCR cases turn out to be false positive?
Yeah, we have seen quite a few cases, especially when the CT value is very high, 37, 38, 39. We have seen it. We have seen that they come in with mild disease and nothing happens to them. They are shocked why they got COVID, and then we check everybody around them. Nobody else has COVID, but it's PCR positive. So we don't know. Maybe it's false positive. And then what happens? Sometimes, rarely, these people come back with COVID again. This time around, they're symptomatic. So we don't know whether this reinfection or whether this first one is false positive. And so it is very tricky sometimes. Yes, if somebody has got no risk factors and the CT value is near the borderline cutoff, 38, 39, sometimes we do repeat the PCR test once again to see. Because the tricky part for us is this can happen because it's false positive. It can happen also because I'm picking up late in the disease. He actually got COVID 2 weeks ago. There also you can have high CT value.
This another question. Any role of UV light as sanitizer in closed environment?
Yeah, provided nobody is inside the room. Yeah, we do use UV lights. It's a good tool. And so what we do is we do have UV light in our Sungai Buloh Hospital, and they regularly come and use UV lights in our common rooms, our pantries, and our changing rooms. We regularly use UV light to kill out all the germs.
Okay.
We have passed 9 actually. Maybe one of our final questions. If you have completed 2 doses of mRNA vaccine, can I proceed to receive another course of inactivated vaccine if available?
I mean, this we don't know because people are already asking us from UK. I'm going to get 2 doses of vaccine. When I come back, can I not quarantine? All these questions we can't answer yet. So what happens is, what will happen will be as more people get vaccine, WHO will get involved, and WHO will now vouch for us and say, if you're vaccinated, then you are immune. So then this question about immunity certificate all will come up because everybody's looking at it for travel. And so I think we'll have to wait for it to see. So we don't know whether we will after the 2 doses of vaccine, we will now ask for a proof of immunity. We might have an antibody test that we do for everybody and see where there's proof of immunity. But we still don't know yet. It's still very early days.
maybe the final question, Dr. Suresh, past 5 past 9 actually. Some patients are given plasma transfusion. Why and when?
So what happened is we did use plasma transfusion earlier, and we are not using as much as before because after steroids came up. So the idea behind that is passive immunity, because we didn't have very good antivirals. So we use convalescent plasma. So we all the patients who recovered from COVID, we asked quite a few of them to come back and donate plasma for us, and use the plasma for patients, especially older age group, immunocompromised hosts who don't have poor immunity and cannot mount immunity. We gave them passive immunization.
Okay, I think we have to wrap up. Dr. Suresh, for your information, we reached a new record today. We had about 1,000 people following you today. Congratulations to you, Doctor. And I think we have to wrap up. And for those online, you have to stay on to please scan your QR code, which we will be displaying after this. Thank you very much for your keen interest in following us. Those who are unable to get a clear picture, we will record this whole talk, and it will be available in the MMA website soon. So thank you very much, and hope to see you in the next webinar section. Thank you. Thank you so much for the IT people in MMA. Our girl here, Jasmine, who worked very hard to put all this together. Thank you.